So I am excited to welcome our next speaker, Dr. Patrick McLaughlin, who is an associate professor for our pediatric emergency department. He is going to be speaking with us this morning about the difference between sending a patient to the emergency department and using urgent care. So good morning, Dr. McLaughlin.
Hi, good morning, everybody. Welcome to Zoom land. I'm halfway caffeinated. I really appreciate everyone joining us today. And let me pull up my share screen and we'll just get started. Okay, so this next segment of our morning, I know this is going to be a little bit challenging in this type of environment, but I've been assured that perhaps if you can either pop your questions into a chat or use the raise hand, or maybe some of our other facilitators can throw some questions my way as they come through. But I'd like this to be about as interactive as we can make it, so that we don't kind of hit all of our questions at the end. And so you'll see kind of where I'm getting at. But I'd like you to ask me, the ER pediatrician, about some of these topics that I've put up here. So honestly, when a child comes in to see you, I think most of the time what you're trying to think of is, can they go back to class, or do I need to call their parents or not? Sometimes it's more of an urgent issue, someone coming in off the schoolyard or coming from physical education class, and you have to go through, is this a common complaint, or is this a red flag that I'm identifying? The red flags, of course, are those that you may want to have a discussion about sending them towards the emergency room for our evaluation. So why is this important to me? Well, my patients call me Dr. Pat, and I hope you guys too. And where am I coming from? I went to school in DC, and that's where I trained. And then by way of the Navy for 7 years, I spent some time in Virginia and South Carolina. And this topic's near and dear to my heart because I was a general pediatrician for about 4 years. During that time, I saw what you see, and I worked with and spent some time with Child Development Center folks and acted as their medical liaison. So we were writing policy and making sure that kids were staying in school that were supposed to, and kids were getting attention when they needed to. Then I decided to go through and complete a fellowship to specialize with what I do now, which is pediatric emergency medicine. And I've been at Children's Hospital of Richmond now for 2.5 years. So the topics I want to address today, I've narrowed it down to 10 topics. You won't see COVID anywhere on the list. I have a feeling you'll get plenty of that throughout the day. And it's in no particular order. I tried to address things just complete alphabetical. You won't see anything more serious versus less serious on this list based on the red flags. So let's get started. So when I hit each slide, and that is my 3-year-old, I gave him a megaphone with his little fire chief outfit that he had. And I said, all right, everyone, Bubba, go ahead and tell everyone that it's safe to go. You can use your megaphone. So he put it up to his ear. And I said, no, it doesn't go in your ear, it goes in your mouth. He said, well, you told me to use the phone. I said, oh, okay, well, that makes sense. So I'd like you to phone in and tell me in the open forum section, maybe share some experiences you've had or particular questions that I can answer about when there's an emergency referral. So let's start with abdominal pain. So most common causes of abdominal pain that you might see are going to be secondary to a viral infection. Enteroviridae, or the class of viruses that kind of infect your gut. They can infect anywhere from your mouth all the way down to your bottom. This can give you inflammation. You can kind of feel uncomfortable, but in general, these things don't require anything more than a little bit of care, fluids, and rest. So this could also be from constipation, and a quick history can kind of sort you into that direction if this is from a gastroenteritis or a viral infection, or if this is constipation. And then, commonly this is related to stress and anxiety at school, and it kind of rears its head as belly pain. But what are the red flags? Well, if this pain tends to migrate, the first thing people think of is going to be an appendicitis. These children are going to be relatively ill appearing. They may say that their pain kind of started around their belly button and then moved to the right lower quadrant. We see a lot of children in the ER for right lower quadrant pain because of an appendicitis. And it's true. In this age group, the school-age child, there aren't many other things that it could be. However, if they start complaining, or you ask some questions and you have some urinary complaints, this could lead to not just a UTI, but it could be a kidney stone in that right lower quadrant. It could be pyelonephritis or an infection in the kidney. So there is some other pathology that we can find from that quadrant. Of course, if the belly pain comes with vomiting, and that vomiting has blood, now you've got an emergent red flag issue. I don't think anyone's going to miss that. But vomiting itself, not necessarily something that needs to come to the emergency room. Typically, rest, fluids, and dry foods will do the trick. Now, genital complaints, what do I mean by that? Belly pain can present as a genital complaint, particularly with boys. If they've got a testicular issue, albeit torsion or a testicle twists, or epididymitis, a small viral infection, that can lead to swelling. But boys aren't going to come in and tell you that they've got a problem down there. They're going to just say it's belly pain. So one thing that I teach young medical students and interns who are new in the emergency room is to make sure that you always ask about and do a genital exam with a child who comes in complaining of abdominal pain. So at this point, before we move on, do we have any questions or other comments about belly pain?
One person stated that they use a 10-minute rule or the 10-minute timer, and they usually go between the 8th and the 10th minute. So that's kind of their rule of thumb for the belly ache or pain.
So using a timing actually isn't a bad idea. In particular, with belly pain, we're looking for a colicky where it comes and goes, or constantly getting worse. Constantly getting worse can be a little bit of a red flag. Belly pain that kind of stays the same. 10 minutes, you may not get a change if it's going to be a surgical issue, but particularly if you get improvement in that time or improvement over any time that a child is with you, it's very likely that it's going to be one of the common causes. Great point. And thanks for sharing. So let's move on to anaphylaxis. Anaphylaxis, of course, is a severe allergic reaction. And let's break that down a little bit, because oftentimes kids will come in with rashes, and that's the unknown rash or unknown possible allergic reaction. And then you've got your children that you are aware of that they have a issue with some type of allergy, and they hopefully keep an auto injector of epinephrine at school. But honestly, what scares everybody is the child who comes in and you don't necessarily know, do I give epi or do I watch and wait and just give some Benadryl, so on and so forth. and you're kind of in the middle. So let me help you determine whether to give epinephrine or not. First off, if you think of it, should I give epi? Give it. No one is ever going to fault you. The parent, the ER physician, the firefighter coming, anyone. No one's going to fault you for giving epi if you had a concern that a child was in anaphylaxis. Be wrong. It is okay. I'd rather that child get emergent epinephrine to prevent possible anaphylaxis than to not get it at all. Because once that cascade gets started, and if you refer to the cartoon that I put up there, the cascade can involve multiple systems in the body. For us, the medical definition of anaphylaxis is going to be 2 organ systems involved. So if a child comes in with just rash, probably not anaphylaxis. If they come in with wheezing, it's possible, but look for that other issue. The child is going to come in after an exposure who complains of an itchy throat, maybe swollen lips, and a rash. That's the child who's going to need epinephrine. And the sooner you give it, the better off that child's going to be. A more common and most often forgotten symptom of anaphylaxis is vomiting. The child who has an exposure to, say, a tree nut of some kind and comes in and vomits and also has hives, that is anaphylaxis. They may not look like they're short of breath. They may not have swelling around the mouth, but any type of stomach issue plus your more common symptoms, that's a child who needs epi emergently. Those kids, and whether they have an epi auto-injector or not, I know that you guys will keep them, making sure that you give it and then send them to us. That's a child who needs evaluation by a physician emergently. They require at least 4 hours of observation. They don't all get admitted, but we'd like to see those symptoms resolve under our care and watchful eye. So even if you get a parent who says, well, thanks, I appreciate you helping my kid, but we're just going to go home, implore them that they should come get a medical evaluation. I don't think you'll run into any issues, but just in case you do. Questions about anaphylaxis and giving epinephrine. While we're getting those, any auto-injector is fine. It's all the same dose.
Whoops. You had one that said, thank you for that information. We are rural and it's a quandary at times whether to give or not to give. So she appreciated that.
Absolutely.
What would be, and another one said that they love that when it comes to anaphylactics, be wrong, it's okay. So they are very much applauding your support on that. Now, one said, should we also give Benadryl as well?
Yes, Benadryl, if the child can tolerate it, you can definitely give Benadryl. And again, the dosing is not something that I need you to worry about. Give whatever the dose is in the pill or whatever the dose is in the liquid. Any type of Benadryl is going to help. If you don't have Benadryl on hand, Zyrtec or cetirizine is another great one. Yeah, cetirizine is a great one because it's long acting. And these children, when they go out, so if you have just a kind of routine allergic reaction and you're going to dose with Benadryl, cetirizine is another great option because it's long acting and will last 12 to 24 hours. Its onset isn't as quick as Benadryl, but it's still pretty quick, 20 to 30 minutes for your Zyrtec. Great question. Please, please, please do not delay giving epinephrine. It's one of those things, if you think about it, be wrong. It's okay. And most times you're going to be right.
The majority are stating that for their locality, that it is a requirement that if they do give the EpiPen, that they must call 911.
Great. Yeah, absolutely. And that goes for children who have a history of anaphylaxis or don't. Sometimes you may run into that issue, like I mentioned, with a kid who has known anaphylaxis and gets epinephrine once a year, that's still a child that needs to come see me. Thanks for sharing and thanks for your comments.
Let's see, I think I was told by a local allergist not to give Benadryl due to the drowsy side effects. Give the Zyrtec or Claritin.
No, absolutely. I would disagree with the drowsy side effects and the concern. Benadryl is going to give you that longer acting blockade of mast cells. Epinephrine, of course, if that turns it around, great. But I'm not worried about drowsiness with medications, because if a child is becoming drowsy from an allergic reaction, that's a very, very late stage finding. And I'm going to see a lot of other symptoms prior to that showing up. You will not mask an exam for me, so don't even worry about that. Thank you.
For Benadryl, swish and swallow, does that matter?
No, it doesn't. Some people think that that's going to help you absorb it quicker, but think about if you had a pill, it's not going to make a difference.
And then liquid Benadryl or pill form?
Both have the same bioavailability. What that means is your body's going to use the medication in the same timeline. The dosing is easier with a pill because you know what you're getting, versus some mild or minor changes with liquid. But whatever you have is fine. I've given 17-year-olds liquid, and I've given 8-year-olds pills.
That's all we got for right now.
Great, thank you. So moving down the line, and similarly, asthma. I was thinking about similarly with wheezing, as that can show up as a complaint with your anaphylaxis. Everyone can take out their smartphone and open up your camera or your QR reader, and you can shoot this QR code that I've popped in there. You can pull it up while I'm talking, because that's my general pediatrician side of things. If you don't have asthma action plans for your known asthmatics, now's the time to kind of review and make sure that parents are getting them filled out. We need you as boots on the ground to help out, to make sure that these kids are managed in a way that they're not going to show up in the emergency room, that they don't need my services. The best way to do that is to have a communication with the family, and for them to communicate with their pediatrician where the child's managed best and what their medications are. There's always a lot of confusion with asthma medicines. Some of them come in pumps or metered dose inhalers, MDIs, and they can easily be mixed up from rescue to daily maintenance medicines. At the same time, people underdose their albuterol. So the first and best place to get that information is from that asthma action plan. So your common complaints, kids are going to pop into your office, are going to be the cough, your wheezers, and your mild shortness of breath. These children, don't hesitate to allow them to get albuterol. And, I think in the terms of an asthma action plan, because if a child shows up with a cough and they're a known asthmatic, they're already in the yellow zone, even if it's mild. So your green zone are your kids' medicines that they take every day without symptoms. That's your management section. Your yellow zone of the action plan is when the first sign of any symptom shows up, even if it's unrelated to asthma. Let's say they feel like, they've got a little congested runny nose and they're feeling short of breath. Great, here's some albuterol, let's do it. They've got a mild cough. Well, I don't feel like I'm wheezing, I'm not short of breath, but I know this cough started. Okay, great, let's do some albuterol. This is another issue that if you head it off at the pass, you're going to stop them from having really bad issues down the line. And that's your common complaints that are going to show up. Your red flags are after you give an appropriate dose of albuterol, there's minimal improvement. They're going to be tachypnic, meaning they're going to breathe very, very fast. They're going to use accessory muscles, meaning you're going to see their chest sucking in and out, perhaps the top of their neck sucking in and out, or their nose, they can have nasal flaring. These children can become a little bit confused and ultimately altered. Those are all red flags that you should be calling the parents and or 911. Because no matter how much albuterol you give, you're probably not going to stop the issue from becoming a problem that I need to see. So I want you to think, when this child shows up and you do dose with albuterol, is this a high-risk asthmatic? Do they show up often because of their asthma? Have there been recent issues? Did they recently go to the emergency room? Were they admitted to the hospital? Or, God forbid, were they admitted to the ICU because of their asthma? If those are issues, those are children you, A, absolutely need action plans for, and B, need aggressive treatment for their asthma. Those are the kids that require steroids quickly. That's something that I can give, and that's something that I would not hesitate getting them access for. Now, the last comment I'll make before I open the floor up to questions is most people feel that an appropriate dose of albuterol is 2 puffs with the MDI, or the metered dose inhaler. Unfortunately, you're wildly underdosing it. The minimum, even for little kids, let's say that 4 or 5-year-old, is going to be 4. Probably when you're talking about high school kids and your 7th and 8th graders, you're talking about 8 puffs. That's once you enter that yellow zone. Now, of course, this is something that you want to have the child talk to their pediatrician, or if they have a pulmonologist, but treating an acute exacerbation requires albuterol, and 2 puffs is never enough. So, the last bonus question: what's better, a nebulizer or a metered dose inhaler? Hopefully you guessed an MDI. So you're probably wondering, well, the nebulizer, that's what you do in the emergency room, isn't it? It's a giant fancy machine. It blows albuterol everywhere. Well, I'll tell you what, it's the least effective way to give albuterol. When you see it flying everywhere, that's the problem. It flies everywhere. It's attached to a water molecule, and that water molecule goes all over the room. It gets stuck inside your mouth. It gets stuck inside your nose. MDIs create laminar or straight flow. And when done properly with a spacer, it's getting right down to the bottom of the lung into the alveoli. And that's where we want that medicine. It's wildly more effective, proven in studies over and over again. And convincing families sometimes is my challenge that an MDI is more effective than a nebulizer. But I'd like to share that information with you so you recognize how much more effective it is. Questions?
All right, you ready?
Ready.
Okay. Let's see. One indicated that they send them home, but have the action plans, but have a really hard time getting them back from parents. In your personal opinion, what could be kind of something to help families understand the value of getting those turned back in?
Well, I think, something's better than nothing. And what that means is, do you need a physician to sign off on it? No. When the parent comes to pick up the child, or the parent's dropping off the albuterol inhaler, pull the form out. Say, hey, do you mind filling this out for me? And essentially what it's going to do is give you an idea of what type of medicine this child takes every day. If the parent can't fill it out, then you have that conversation with them and say, can you bring this back with the school form? And that hopefully will help you get some more information.
And I think the option you posted was just so that they could understand that there were options available for an action plan.
Yeah, and I put the one that's associated with Virginia, but of course they're all pretty much the same, right, if you get it off.
And so someone indicated that, let's see, where was it? Their school used a different one, but then also Tracy indicated they are available on the VDOE school nurse website. So really the point to drive home is that you use it, get That's parents right. to fill it out, have it available when you can.
That's right.
Let's see, it is such a struggle to get asthma action and LAMP forms. I get a lot of their asthma isn't that bad, or with anaphylaxis, they know what to avoid their allergy.
I used to make it a policy that whether it's severe or mild, I have documentation of the child's condition and medicines.
And that's to protect everyone.
It's a hard stop. So, once you start the documentation process, and it can be coupled with the school forms, the vaccination forms, the annual physical that needs to be filled out. Those high risk children are the ones that you need to keep the closer eye on, and everybody knows who they are because they're typically in your office more than the other kids are. Those are the ones that, regardless of if they've been admitted 4 years ago or they were admitted 4 days ago, making it a hard stop that you'd like that information.
There is new inhaler legislation. Do you have, or have you seen that? Do you have any thoughts on that? It says, how will this look for us in schools without MD oversight? We have been told to reuse inhaler and or spacers for different students.
So I have not seen that. I have never heard of reusing the same MDI. Certainly not reusing the same spacer. That's the aero chamber tube that allows you to use it more effectively. But I guess technically using a different spacer but the same medication device, the MDI, shouldn't be an issue, but I haven't seen that legislation. I'll check it out, and I can always shoot an email back, but that sounds interesting.
Tracy just commented that the Department of Education and VDH is working on that. So okay. more to come.
More to come.
More to come.
It's always best to have the child use their own, and not one that's just sitting around in the office, but so do your best to obtain that. Okay, thanks for sharing, everybody. We're going to move on to the next slide. Asthma is always a hot topic. Hopefully,
can you answer real quickly?
Yeah.
How far apart should the 8 puffs be?
Great question. So, you can actually YouTube the videos, and there are links from either Journal of Asthma or various reputable resources, as opposed to just someone putting a YouTube video up. But essentially, giving the dose, priming the chamber, so that means give a puff into the chamber, not on the child's mouth. That gets the chamber full of medication. And then giving a dose, allowing the child to breathe. You don't have to wait longer than 30 seconds to a minute, but certainly you want to at least wait 30 seconds. Now, if that child looks like they're in distress, you can go less and do 15 to 20 seconds, but as long as you're not doing puff, breathe, puff, breathe. You're going to find multiple ways and multiple people to tell you what's best, but essentially give the child time in between each dose to slowly inhale and allow the medicine to get where it's supposed to go.
All right, another one that's a really good question. For a child having an asthma episode with no asthma medication in the clinic, at what point would I call 911 versus parent to pick the child up to be treated? So
I would look for the red flags. Certainly, so minimal improvement's only going to be after albuterol, but tachypnea or rapid breathing, that's a sign of, that child is in distress. And your typical asthma attack is going to come with cough and wheezing. But once you're breathing fast, or if you get altered, meaning that child seems sleepy, tired, out of it, that's a 911 issue. I don't want to get in the weeds with, how many letters can they say, because another way that we look to see level of distress is how many letters they can say of the alphabet before they have to stop to take a breath. So if they go A, B, C, D, E, F, G, H, I, J, or is it A, B, C, D? So those types of things, it's all levels of tachypnea and distress. And honestly, again, you shouldn't be faulted for calling 911. It's just like epinephrine. You're never going to be faulted for doing the right thing.
And then the last one, what about infants that we have at 6 weeks of age in our program, MDI versus nebulizer?
Ooh, so that's a whole ball of wax so that, asthma as a diagnosis isn't made until at least 2 years old. Now, there are caveats. Children who are born extremely premature and have something called bronchopulmonary dysplasia, children who have had hospitalizations that we have documented albuterol works, but children who are being prescribed albuterol at that age, it's not proven to work unless they have a pulmonologist and a very highly specific reason that they need it. Again, I don't want to get lost in the weeds with RSV or bronchiolitics, but bronchiolitis, no matter what the cause, has never been proven to improve by using albuterol, by using steroids, by using nebulized saline, by using anything like that outside of oxygen. So if a 6-week-old is being prescribed albuterol, no matter how it's being delivered, I would question the source. A little off topic, but very important. Thank you.
You may move on.
All right. So I'm going to say this at the onset. The next 2 slides are pretty much the same topic, but in a different spin. Closed head trauma. So your common complaints, kids bonk their head, they've got a headache, they've got a goose egg on their forehead, maybe they have a bloody nose because they were hit in the face, and they're fatigued and tired. So in my world, and what I'd like to introduce to you, if you haven't seen it already, is the PCARN Pediatric Head CT rule. PCARN is the Pediatric Emergency Care Applied Research Network. Why is that important? Well, we took several pediatric hospitals around the country and studied kids who come into the ER with that exact complaint. The complaint is we had closed head trauma of some way, and do we get a CT or not? Well, why is that important for you? Because you're probably thinking, does this child need to be seen in the emergency room from them bashing their head? If you refer to the cartoon in the middle, ultimately, anyone who falls into the 2 top categories needs an ER visit and an evaluation by me. If you're altered, if your Glasgow coma score Is GCS less than 15? Do you have to worry about what that means? Not really, because it's the same as being altered. Signs of a basilar skull fracture: the base of the skull is going to be anywhere other than the front of the head. The front of the head is very strong and designed to take impact. The back of the head, not so much. So if you have, if you touch the skull and it moves, obviously that's an issue. That's a sign of a basilar skull fracture. If you've got a very large hematoma on the back of the head or swelling, that's a sign possibly of a basilar skull fracture. Any loss of consciousness, so kid was knocked out, kid was woozy or dazed, is not loss of consciousness. Any history of vomiting in a child greater than 2 years old after head trauma needs an evaluation. Severe headache, worst of their life. Severe mechanism. Now, you may question, what's a severe mechanism? There's great pictures on the bottom of this that tells you, was this child struck by a vehicle? Were they in a car accident? Were they riding a bike and fell without a helmet? Those are examples. And the big one that you're going to see most often is the height of a fall. If it's greater than 4 to 5 feet, that is considered. So someone who's at the top of the slide and falls down. If you fell off a swing, if you fell off a step or two, if you fell down the steps. So in our world, we consider falling down the steps not a 15-foot fall. That's 15, 12-inch falls. So even though it looks violent, it's very unlikely that there's closed head trauma that's going to relate, unless you've got some of these other red flags that I've pointed out. So if you've gone through this list and you found that this child doesn't meet any of those things, an ER visit isn't necessarily recommended. Now, closed head trauma, and if you notice, I've written rest to recover. Fatigue and being tired is very important. It's an important part after a closed head trauma, because that's their body telling them how to heal. Some people think with a concussion after closed head trauma that you got to keep them awake. That's a problem if they go to sleep. In fact, it's the opposite. And so let me share this story with you. If a child comes in and they broke their ankle, the best treatment is not to go run a mile. The best treatment is to rest it, to elevate it, to put some ice on it. If you have someone who just bonked their head and now potentially has a concussion, and you try and keep them awake, you're actually telling that fractured ankle to go run a marathon. So contrary to popular belief from decades ago, where people thought that perhaps you need to keep an eye on those folks and keep them awake, it's actually 180 degrees and complete opposite of what you're supposed to do. Now, the less concerning for me result of closed head trauma is a concussion. Less concerning because I know there's nothing wrong that requires emergent care. Concussions are commonplace. The complaints you're going to see are going to be after blunt head trauma, dizziness, headache, sometimes amnesia of the event. But then you've got a slew of red flags. And these red flags can bring you back to the previous slide. And then you're looking at, does this child need an emergent visit? I would say if you run this list in yellow and the child has any of these red flags and you suspect concussion, that could be a sign of something more. Concussions in and of itself, there's no testing for it. There's no CT scan that can diagnose it. I put another QR code up. I don't know if you've zapped it with your phone yet, but that QR code goes to one of the best created questionnaires for concussions. It's rather lengthy, so I'm not a huge fan, because I like things quick in the emergency room. But if you really want to delve into the types of questions that you should ask a child to help you recognize if there's a concussion or not, then I would use this questionnaire. Most often people come in and they want to know, well, how do you diagnose a concussion? Sometimes I can ask the questions today and I can tell you, yeah, I'm pretty sure there's a concussion going on. Sometimes it takes a couple days. And so that's why you're at the front line, and I know that line is going to be said a lot today, but you really are at helping to diagnose and manage concussion. The things in yellow are what I'm curious in, because that could be a sign of something deeper. Now, I'm going to dedicate at least 3 to 4 minutes on this because I'm sure there's some questions.
You actually, maybe they're just brewing. I think they're brewing.
Okay, brewing is fine. Brewing's good.
I think right now they're not, with the limited amount of children in school, I'm not sure that they're seeing as many of these as they probably have in the past.
And it's relatively straightforward. If you haven't seen this pediatric head CT rule, then I'm glad that I've introduced you to it. I've placed a link to this study on this slide. You're more than welcome to read it. It's a fantastic study. And then, in addition, keeping this list handy. Maybe we'll have some questions at the end. There's a couple topics I kind of want to breeze through because it's relatively cut and dry when you're going to send a child to me in the emergency room. Everyone's got the diabetics. These are children that you know probably intimately. Their common complaints are going to be my monitor's telling me my blood sugar's high. I feel a little bit dizzy, whether that's from low sugar or high sugar. That's something that you can easily sort out with a finger stick glucose, or my pump seems to be broken. The red flags, of course, and the biggest thing that we worry about is DKA. That stands for diabetic ketoacidosis. That's when the blood sugar is sustained high and you can't bring it down with their normal insulin. You're going to notice things like vomiting, rapid breathing. They're going to be really excessively tired or weak, sometimes complaining of abdominal pain and headache. A diabetic with any of those symptoms, even if you think, well, this kid could just have garden variety virus, I want you to make sure that you're checking blood sugar. Sometimes you're checking urine, and then send them my way. The kids that you need to stop and think again is this a child who's poorly compliant? We often see that with our teenagers. And do they have ketones in the urine on a urine dipstick? If they do, err on the side of caution and send them to me. Let us sort it out. Questions about that? Relatively straightforward.
You actually now have one about once they were able to digest your concussion information, it did register a question.
Sure.
What do you do about the student that is showing some confusion, mild symptoms after hitting their head, and parents don't want to take them to see an MD? Send them home,
I believe,
possibly alone versus stay. What are your thoughts on that?
That's purely that's purely up to the parents. Confusion is common, headache is common, and particularly if it's a frontal head trauma. It's pretty rare that a frontal head trauma is going to yield anything that's emergent. Now, caveats: severe mechanism of injury. Two kids running into each other going up for a header, not a severe mechanism of injury. A kid hit with a baseball bat into the head, that's pretty severe mechanism of injury. And then the yellow list that I've got here, those are all kids that it could be more than a concussion. Vomiting is going to be your most common complaint, and or severe headache. And who's to say what's severe and what's not severe? That's for the parent, the child to recommend whether they come to see me or not.
Let's see. I'm getting another one. So in relation to a suspected concussion criteria, when should you let the parent take them to a healthcare provider, or when to call EMS? Kind of, is there a kind of a if this then that? Go back to your chart.
Of issues, you're going to call EMS.
Perfect.
And it's going to be more or less, hello, Mrs. Smith, your child sustained a kick to the head today, and they've been vomiting ever since and complaining of a severe headache. I'm calling 911. Would you like to meet me here? You know, I'm worried and I think that they need an evaluation. You can allow this image, this cartoon in the middle, to dictate when 911 is called. Hopefully I've kind of made it relatively straightforward.
Right, and that's your professional recommend, like this is kind of the cut in.
Correct. Yep. These can be a little bit of a gray area, but I put these up as a long list of red flags because they're not necessarily common. But if they are, if it happens, then that's when I would implore that they come for an evaluation to make sure there's nothing more severe. That doesn't mean I'm going to do a CT scan. It doesn't mean that I'm going to need to do any extra testing, but they should probably have an evaluation by a physician.
One comment is, I find it hard to get parents to understand the need to decrease screen time with head injury. Any advice there?
So that all depends on, and that's getting a little bit into the weeds, but it depends on the recovery of the child. The QR code that I put up on this screen is a questionnaire that you can use at the time of the incident, and you can do in stepwise fashion out to see how they're tolerating activity. If you identify that the child is not able to tolerate certain levels of activity, this could give you the proof that you need to give to the parent to say, hey, listen, this is where your child's scoring. It's not much better than what they were previously scoring. And hopefully that'll help you build an argument. But you know, that's tough.
This one is going to go back to your diabetes topic. My students are below second grade and usually use syringe. Sorry, it just hopped on me. Where'd it go? My apologies. My students are below second grade and usually use syringe and vial. Do we still wait 3 hours for hyperglycemia to prevent stacking?
So good question. Honestly, that is a great question for the child's parent and or the child's pediatric endocrinologist. If you feel like you're correcting, so let me put it to you this way. Hyperglycemia for a short amount of time, not dangerous. Hypoglycemia for any amount of time, potentially very dangerous. So erring on the side of not stacking insulin to prevent hypoglycemia, very important. Short amount of time, hypoglycemia, bad. Long amount of time, hyperglycemia, bad. That's where you can get into DKA. And so if you're kind of worrying about that middle ground, that's a great conversation for that child's parent. And that child's parent, I'm sure, would probably discuss it with their pediatric endocrinologist.
Let's see. When you say send him to me with a diabetic child who has ketones in his urine, can you clarify if you mean send him to the ER or urgent care? I think they want to know where you hide out.
Always to me.
Which is the emergency department.
That's correct. It's the emergency department.
Yes.
And, any of the common, so let me put it to you this way. The list of common complaints that I'm running through, those are things to discuss with the child's parent and or pediatrician. Once you hit red flags, those are issues that should be sorted out in a pediatric emergency room or your local emergency room if you don't have access to a specialized pediatric one. I don't typically recommend using urgent cares outside of parent preference, meaning the child's vomiting at home and they don't know what to do and their pediatrician is closed. I think the in-between and the hard stop for you is going to be common complaints and deferring to the parent, red flags and deferring to an emergency room. Hopefully
so if someone needs
a
flu test or a COVID test, that's urgent care. You don't.
That's very, yes, exactly.
Yeah. Mm-hmm. Yes. A question about inhaled glucogen is new. Can you give any advice on that?
I don't have advice to give because it doesn't necessarily come up into the emergency room realm. Certainly, that's something that if you have a child who's initiating treatment with, it's not unheard of. And I don't want you to feel like you're out of place to actually have a conversation with that child's specialist. So I'll give you an example. Just like the example you brought up with inhaled glucogen. If you have an asthmatic who's on a monoclonal antibody injection therapy for their severe asthma, and you've never heard of it and you don't know what it is, and you just want to get more information, first talk to the parent because they're usually relatively educated. But if they're not, ask the parent for the contact information or the pager number to their specialist. Reach out. I know and work with all the pediatric subspecialists at Children's Hospital of Richmond, and they're all very, very open to discussing with a parent's, of course, permission. But if the parent gives you permission and you have questions, let us know. Let us help you sort it out.
Yes, thank you for driving that point home. I think a lot of times our frontline people think that they're bothering the specialist or the provider, and that's not the case.
Not at all.
The specialist or provider always wants what's in the best interest of the child, and they always want to be educating to make sure that their patient is getting the best care, even when they're not under their roof.
That's right.
So let's see, no more questions right now.
Okay, great. So, Carol, I see my timer and we're getting down to about 5 minutes. Is that correct?
Yes, sir.
Perfect. So, we could stay on this slide for probably 15 to 20 minutes, but let me simplify it for you. Because fevers are a symptom. They're not a disease. They're not guaranteed infection even, but it's a symptom. It's no more or less than a symptom as belly pain, as vomiting, as headache, as runny nose, as cough. It's a symptom. It's telling you which direction potentially to look, but it doesn't mean that it could be serious or not serious. It doesn't even mean, like I said, that it's infection. It could be an autoimmune problem. It could be any number of things. So making sure that when you check a temperature, it's reliable, meaning the device that you're using is reliable. Now, I know you don't always have the best access to the most reliable devices and you got to go with what you got, but making sure you go with what you got and it's actually a true fever is important. The child's typically going to be previously well, meaning they didn't recognize there was a fever. It may be accompanied by chills or rigors where you're shaking. That's not a seizure. That's just a result of the fever. And then it's usually going to come with fatigue or tiredness. So red flags. This list is very vague, and I left it vague because almost none of these reasons mean that you need to come to see an emergency room. They also don't mean you need to see anyone in an urgent care. Would you like to talk to the child's pediatrician, meaning the family should get in touch? It's possible, but not every fever you need to do that. So again, it's a long, wide gray area. Does this child have medical history that would lead them to be an issue? If this is a child with sickle cell anemia, that's something that should be seen in the emergency room with fever. But does this child have a history of strep throat? No, doesn't need to come to the emergency room. Additional symptoms along with the fever, and that's just going through a review of systems, meaning from head to toe. Sometimes additional symptoms plus the fever, meaning I've been coughing for 3 days, now I'm short of breath and I have a fever. That's a child that should be evaluated by a physician. Whether it's in the emergency room or not, totally up to the family. Focal findings, that can help dictate if this is something that the fever is caused from the focal finding. My ear hurts, my mouth hurts, my throat hurts, those types of things. Or there's a big red rash on my leg, plus a fever. Those types of issues would probably get evaluated, but not every fever needs to be evaluated. So besides opening Pandora's box, I'm going to kind of leave that there, and hopefully I've said enough and bring it to my last ending list. So these slides are going to be available for you, but I'm going to skip them because of time. So honestly, and I'll strike home this point. If you're in doubt, please don't hesitate to talk it out with the family, talk it out with the child's pediatrician, talk it out with the child's subspecialist, or talk it out with us in the emergency room. What I hope to do is empower you today, empower you to know that when you're making a decision, you're making that decision with the child's best interest at heart. Parents may not recognize that all the time. School administrators may not recognize that all the time, but feel empowered to make that decision nonetheless, because we've got your back. And essentially making a decision for that child in their best interest sometimes means doing something that you're worried should you do it, like giving epinephrine or calling 911. No one's going to fault you for making that decision. But if you need us, that's why we're here to talk. The list of common complaints, red flags that go along with them, they're a guideline. They're not a rule. As my children will tell us as they're learning about community, laws, and rules. Is that a rule or a law, Dad? Well, mostly these are rules. None of them are laws. The ones that are more set in stone should absolutely be seen by an emergency room physician are going to be your children who've been treated with epinephrine or any child you identify to have suicidality. Believe it or not, that whole entire list up there, those are the ones that are black and white, need to come to the pediatric emergency room or any emergency room. The rest of them, let the red flags guide you. And there are red flags that I have not identified today. There are probably red flags that you guys can teach me about, but use these as a guideline. So last couple minutes for questions here.
The last question that we got was a large amount of the localities are now using the temporal thermometers. They're finding that they're not necessarily accurate. Is there one that you've encountered that you believe is more accurate than another?
So scanning thermometers that use the temporal artery or if it says on it arterial scan, anything from the artery scanning, those are going to be more accurate. Obviously, oral or rectal, if you're in a daycare situation, rectal temperature in the children less than 12 months old or less than 24 months old is most accurate when you can't get oral. And then oral, for anyone older than 12 months old that can cooperate. Outside of that, it's the arterial scans. If you don't have access to it, you're doing the best with what you got. And sometimes taking the temperature, making sure the child is comfortable, and then rechecking the temperature 5 to 10 minutes later, that's not unheard of. And it may give you a more accurate reading. I'm not sure. You've got the best that you've got. And especially in the time of COVID, with all the different ways that we're scanning for temperature, accuracy is not always the best. But if it's going to be elevated, it's not going to be just by 1/10 of a degree. It's going to be up. We're talking over 101. So 101 or above in any other way that you find it is probably true fever.
Good baseline. One last question. It looks like students who have been taking substances with elevated heart rate and blood pressure, would your recommendation to be 911 send to the ER?
So substances meaning illicit substances,
yes.
like drugs?
Yes.
Again, it's a pretty wide gray area. I'm going to see the children who have overdoses, or if there's a concern for overdose, that's a child that needs to be evaluated. A lot of drugs, illicit or otherwise, even your ADHD medicines can give you tachycardia or high heart rate and hypertension or high blood pressure. And those things aren't necessarily harmful and are relatively common. There's no real emergent intervention that needs to happen. So I would say, if you're looking for a rule of thumb, if you have concern for overdose, that child needs an evaluation. If you don't think there's overdose, then I think you let the parent make that decision.
And then the last one, which I think is great, is thank you for your red flag notations, which will help new school nurses coming aboard our schools. So they really appreciate that kind of as a rule of thumb.
Good, yeah, and I'm glad you've got this as a reference now. It's a resource at your fingertips, and I look forward to eventually meeting everybody in person and having a very fun, interactive talk. Yes.
Thank you. We greatly appreciate your time. I know that you're busy, and so great response, and have overwhelming appreciation in the chat box.